Rheumatoid arthritis is often called joint pain, but that phrase hides a bigger story. Imagine an immune system that mistakes the lining of your joints for an enemy and mounts a chronic attack. This is not short-lived soreness, it's a systemic, autoimmune inflammatory disease that, if missed or undertreated, can quietly damage joints, sap energy, and affect organs. The encouraging truth is that modern medicine understands RA far better than before, and powerful treatments can prevent long-term harm for many people. Rheumatoid arthritis. RA is chronic, systemic, and autoimmune. Chronic means it typically persists for years. Systemic means it can affect the whole body, not just isolated spots. Autoimmune means the immune system is attacking the body's own tissues. RA most often targets synovial joints, the movable joints that let fingers, wrists, ankles, and knees bend and flex. It commonly begins in the small joints of the hands and feet and usually shows up on both sides of the body in a symmetrical pattern. A hallmark is morning stiffness that lasts longer than the stiffness of simple overuse, often more than 30 minutes, sometimes hours, gradually easing with movement. That pattern helps distinguish RA from osteoarthritis, which is largely a mechanical wear and tear problem and usually feels worse by the end of the day. RA, by contrast, is driven by inflammation from the inside. To picture what's happening inside an affected joint, start with a healthy joint. Smooth cartilage covers bone ends, and a thin synovial membrane lines the space, producing lubricating fluid. In RA, the immune system zeroes in on that synovial lining. T cells, B cells, macrophages, and other immune players gather within the joint and release inflammatory messengers, cytokines like TNF-alpha and IL-6 among them. The synovial membrane thickens and grows into aggressive tissue called pannus. Pannus behaves like an inflamed, invasive soft tissue that creeps over cartilage and bone, gradually eroding them. Over time, this process leads to swelling, warmth, pain, persistent stiffness, loss of grip strength, and deformities in the hands, wrists, and feet. Untreated, these changes can reduce function and independence. RA is more than aching hands. The same inflammatory process can create fatigue so deep it feels like being perpetually run down. Some people have low-grade fevers or develop anemia linked to chronic inflammation. Rheumatoid nodules, firm lumps under the skin, often over pressure points, can appear. In some cases, inflammation affects lungs, producing interstitial lung disease or pleural effusions, and the eyes may suffer scleritis or episcleritis. Importantly, chronic systemic inflammation raises cardiovascular risk. In severe, long-standing disease, blood vessel inflammation, vasculitis can occur. This broader view explains why clinicians take RA seriously. The goal is to protect not only joints, but overall long-term health. Why does RA happen? There isn't a single cause, but several interacting factors clarify the risk. Genetics matter. Certain HLA-DRB1 gene variants, called shared epitope alleles, increase susceptibility by affecting how the immune system presents antigens. Environment also plays a role. Cigarette smoking is one of the clearest, strongest risk factors and particularly augments risk in people with those genetic variants. Other environmental triggers under study include periodontal disease, some infections, air pollution, and occupational exposures. Many people with RA develop autoantibodies, rheumatoid factor, and anti-citrullinated protein antibodies, anti-CCP or ACPA, often years before symptoms arise. These antibodies are linked to a more aggressive, erosive picture. Hormonal and demographic patterns also influence RA. It's more common in women than men and often begins between the 30s and 60s, suggesting sex hormones and immune regulation shape risk. Ultimately, genes, environment, and immune misrecognition combine, so the immune system stops tolerating joint components and attacks them. Diagnosing RA relies on a synthesis of findings rather than a single definitive test. Clinicians consider the pattern of joint involvement. Small, symmetrical, multiple joints, the duration of symptoms, typically more than 6 weeks, and physical exam evidence of swollen and tender joints. Blood tests such as rheumatoid factor, anti-CCP, ESR, and CRP inform the picture. Imaging, plain X-rays, ultrasound, or MRI can reveal synovitis and early erosions. Classification criteria developed by international rheumatology groups use joint counts, serology, symptom duration, and inflammation markers to identify RA early. While designed for research, they guide everyday clinical thinking and early intervention. Treatment today aims to prevent damage, not just relieve pain. The treat-to-target strategy emphasizes starting effective therapy early, monitoring disease activity closely, and adjusting treatment until low disease activity or remission is reached. DMARDs, disease-modifying anti-rheumatic drugs, are the backbone. Methotrexate is the common first-line choice. It reduces inflammation and slows or halts joint damage in many patients. Other conventional DMARDs include sulfasalazine, hydroxychloroquine, and leflunomide, sometimes used together. Biologic DMARDs target specific immune pathways. TNF inhibitors, Illinois 6 blockers, agents against B cells or T cell co-stimulation. Targeted synthetic DMARDs like JAK inhibitors block intracellular signaling involved in inflammation and are available orally. Short-term corticosteroids and NSAIDs can help control symptoms while DMARDs take effect, but long-term management focuses on drugs that change disease course. Supportive measures, physiotherapy, exercise, joint protection strategies, smoking cessation, weight management, and vaccination complement medical therapy, and care is best coordinated by a rheumatologist with a multidisciplinary team. Living with RA affects body and mind. Chronic pain and fatigue can challenge identity, work, family roles, and mood, increasing risk of anxiety and depression. RA is a biological disease, not a sign of weakness, and modern therapies let many people reach low disease activity or remission and continue active, fulfilling lives. Early recognition of persistent joint swelling, pain, and morning stiffness, and early rheumatology involvement make a substantial difference. Understanding what RA really is the first step to controlling it, so it doesn't quietly control you.